Thanks everybody for joining us today for our September Learning Cafe, hosted by the UT Graduate School of Medicine Center of Excellence for Children in State Custody. My name is Caleb Corwin. I'm a psychologist here at the COE. I want to thank everybody for joining us and invite everybody to introduce yourself in the chat box. Let us know your name and where you're coming to us from, what your organization is, so that everybody can do a little bit of networking so we can see who's with us today. I am one of our psychologists, and I'm going to be the one presenting to us today. And so I just encourage everybody, as I'm presenting, if you have any questions, hit up the chat. I'll try to answer those as best I can. If you don't feel comfortable asking your question out loud, you can always email us. The information should be in the chat below. Karen, our lovely administrative assistant, is going to be dropping a copy of the slides into the chat. If you need those, they'll be there, and she's going to drop them a couple of times. If you want those, if you forget to get them out of the chat box, you can email us later, and we're happy to send those along at that point. Today, I'm going to be talking to you all about evidence-based assessment of ADHD, and specifically highlighting some differential diagnostic considerations. So this is going to be targeted more at people who are mental health professionals who are working with children and doing those diagnoses, but hopefully this presentation is going to be useful for anybody who works with children who have ADHD and maybe accompanying them on a visit to see their mental health professional as well. So as we get started, one of the things we gotta talk about first is, when we talk about ADHD, what are we talking about, right? We want to make sure we're all on the same page. So with ADHD, one of the things that we need to just lead off with is we're talking about an incredibly prevalent condition. ADHD is known to be worldwide. You can see here prevalence rates from all over. And what you'll see is that in the United States, in this infographic, it's highlighted that the prevalence rate is around 5%. What we see is that for most of the studies that have come out, we are seeing prevalence rates somewhere between 5 and 10%. We're seeing a lot of people diagnosed with ADHD. It's pretty common. The other thing is, we know that ADHD is highly heritable. We know that it has a tendency, a pretty significant tendency, to run in families, and we see it being more heritable than schizophrenia, but not quite as heritable as height. So this means that if you see a family where, if you have a kid who has ADHD, there's a high probability that you have one of those two parents, if not both parents, potentially having ADHD, and that other siblings in the household are highly likely to also have ADHD. This is something not voluntary, right? Highly heritable. We also see that for ADHD, we see that can be a big environmental component. It's one of those disorders where multiple causes can lead to the same outcome. And so we also see that there are a variety of different insults that can occur perinatally and lead to executive functioning deficits, which are often diagnosed as ADHD. Some of those include premature birth, low birth weight, brain injury. We're also seeing high rates of ADHD diagnosed from kids who were born with neonatal abstinence syndrome, which is unfortunately very common, but unfortunately we see high rates of that in our area of East Tennessee. We also see ADHD commonly diagnosed among children born with fetal alcohol spectrum disorder. One of the typical agreements among the literature is that substance exposure in utero increases the risk for executive functioning disorders, regardless of what substance that is. And so really, we see those insults. We're looking at kids who are more likely to have ADHD. And in my own personal experience, some of the kids that I've worked with NAS have been some of the most severe ADHD cases that I have seen. Not always the case, but can be. We're also talking about with ADHD something that I think with ADHD, we're talking about a developmental delay. We're talking about kids with ADHD who present as being a couple of years behind their same age peers in their ability to think things through, make decisions, learn from consequences, right? Johnny may be as tall as other 10-year-old boys, right? He may be as tall as other 10-year-old boys. He may run as fast as other 10-year-old boys. He may jump higher than other 10-year-old boys. But if he's 10, right, he's right here. Most 10-year-old boys are right here with their cortical development, part of prefrontal cortex for their brain development. Where Johnny with ADHD, he's actually down here, which is where these kids were without ADHD. That's where they were when they were like 7. So we're seeing these kids with ADHD appearing to be, somewhere between 2 to 4 years behind their same age peers in their ability to control their impulses, sit still, pay attention, right? Because that part of the brain isn't maturing as quickly. It is an invisible developmental delay. We also know that ADHD is chronic and can be lifelong. This infographic, I feel like, is very helpful and outlines just the typical trajectory. We see most children come in with their impulsive and hyperactive symptoms of ADHD occurring very early on, and the inattentive symptoms really becoming noticeable around school age, which is why in many instances we like to do an assessment around this age. That's when we really try to look for those things and try to manage things behaviorally until that point. But the other thing I want to highlight here is that what we see is as children age, the impulsivity and the hyperactivity tends to drop off, so that around adulthood, we're starting to see these adults with ADHD looking far more like their typically developing peers. The difference is we do see more often that the inattentive symptoms will persist well into adulthood, which is why that behavioral therapy component can be so critical, as it can work to teach those kind of organizational and self-management skills that can persist to manage the inattention throughout adulthood. We also see that for a lot of people, comorbidity starts to be recognized where it may exist. We know ADHD is highly comorbid with a lot of other disorders, specifically anxiety, depression, and those tend to be more identified once the impulsivity and hyperactivity drop off and are less concerning as we approach adulthood. So I'm not going to sit here and read through the diagnostic criteria with you. I encourage anyone who's not familiar with it to look into that to get to the specifics. But one of the things is when we're diagnosing this, there are specific parameters that are given for how we're supposed to consider these diagnoses. One of the first things is when we diagnose ADHD is that we're looking at whether or not ADHD is predominantly hyperactive impulsive, predominantly inattentive type, or whether or not we're talking about combined type, right? Which means that somebody's meeting both of those criteria. Historically, what we talked about is ADHD versus ADD, right? Do you have attention deficit hyperactivity disorder or attention deficit disorder without that hyperactivity? We've since gotten rid of that ADD category, and now everybody who has ADHD is diagnosed with ADHD, right? Even if you don't have the hyperactive impulsive type, you would be ADHD predominantly inattentive type. These specifiers can be somewhat helpful to a certain degree, because what we know is that people who have predominantly inattentive type tend to be less frequently identified than those who have combined type. We also know that the majority of the research that's been done to date has been done on this combined type. These kids who have a higher rate of symptoms and more overall symptoms. And one of the other things that I think is really important to understand is if we track children with ADHD over time, what we see is that they often move between these categories. So they may have been diagnosed with predominantly hyperactive impulsive type when they were 4. But when they're reassessed at 9, they meet criteria for combined type. And then when they're reassessed at 15, now they're predominantly inattentive type. And so we see a transition, and that's not always the progression, but we will see people move in and out of these categories while still meeting criteria for ADHD overall. And so really, to date, we haven't found that identifying between these groups is very informative for our overall treatment plan, but it is a designation that if you're making a diagnosis, you need to make that designation and work to make that designation here. One of the important diagnostic criteria, or one of the diagnostic criteria that's listed, is that symptoms need to be present before age 12. Previously, the cutoff was earlier around age 7, right? We needed to make that cutoff before kids, that they had to have symptoms before age 7. We found that that was too prohibitive, that there were too many kids who symptoms weren't being identified or recognized until after age 7, who were consistent in all other ways to other children who had ADHD. And so what we're looking for is that several symptoms were present before 12. It doesn't mean a kid, if you're not diagnosed before 12, you can't have ADHD. There are people who are 33 who have ADHD that was never identified when they were a kid, but when you talk to them, there were several symptoms of ADHD that were present at age 8. And that's what we're looking for. Several symptoms present before age 12. The idea being that if you didn't have any symptoms, or like maybe only one symptom of ADHD prior to age 12, and then all of a sudden at 15, you're exhibiting all these things, we're going to look at other causes. Did you have a brain injury? Is there some type of dietary change or other biological change that occurred in your life that could have triggered this? Or is it related to some traumatic event which just occurred, which can very much look like ADHD? We'll talk more about that later. Another important criteria is we're wanting to make sure that these ADHD symptoms are present in 2 or more settings. If we see a kid and they meet all criteria for ADHD, but those symptoms are only present at home, I'm not going to diagnose ADHD, because what we're saying is this kid behaves really well at school, focuses at school, sits still at school, is not impulsive at school, but is really impulsive and doesn't listen at all at home. Well, there are probably a couple of things that could be going on there. One of the things I'm going to be thinking, though, is, well, is the teacher paying attention at all when she's rating this? Does the teacher know this kid well, or have they only seen them for a week and we're in a honeymoon phase? Or is there something going on at home and something that's unique about that environment, the way it's set up, that may actually explain why the kid behaves in that way in that setting? And so for ADHD, we're talking about a diagnosis that is expected to be more pervasive. We're talking about something that has a biological basis, where we're not expecting that a kid is going to be able to very easily turn it on or off. We know that kids with ADHD can focus, and they're more likely, just like everyone else, to be able to focus on things that interest them, which is why we see kids with ADHD can focus when they're playing their favorite video game, but really struggle to focus when they're in their least favorite class, right? Which is true for all of us. If we're watching our favorite TV show, we have a much longer attention span than we do if we're in our least favorite meeting of the week, right? And so we see that to be true, but we want to see this difficulty is occurring across the board, right? It's occurring in multiple different settings. Typically, we look at home and school, but really we can look anywhere for this deficit, right? It could be at their sports team, it could be in their youth group, it could be in their swim lesson, right? We're looking for these symptoms, several of these symptoms, to be present in more than one setting. We're also understanding and running to pay attention to whether or not we're seeing some type of dysfunction. We're not diagnosing any disorder in the DSM without some indication of some harmful dysfunction occurring. And so we're looking that not only do they have these symptoms, this hyperactivity, impulsivity, and attention, but what type of negative impact does that have? And we know for ADHD, when it's really there, it can have a lot of negative impacts. There are a lot of things that lurk below the surface of ADHD that are really negative outcomes for kids, and that can cause them lifelong difficulties. And so really, we're only diagnosing ADHD. I mean, if we have a kid who's hyperactive and impulsive, but doing great in all aspects of life, getting along with their family, everything's going well, I might not diagnose it, and I might consider that kid's hyperactivity and impulsivity is maybe more developmentally appropriate, more what I would expect, right? It's unlikely to be the case that it would be developmentally inappropriate and wouldn't be causing any deficits. Because what the evidence supports is this idea that for kids with ADHD, they've got a lot of negative outcomes associated with them. Kids with ADHD are significantly more prone to accidental injuries. And if we think about a kid who struggles to learn from consequences, has trouble sitting still, is always running around, right? More prone to jump down a flight of stairs without thinking about it, try to pop a wheelie on a bicycle without a helmet, try to be the first to jump off of a rope swing that nobody else has been on before and land on a rock, or the rope breaks and they get hurt, right? Lots of things we could think of. And if we've known someone with ADHD, like, yeah, they definitely were always in a cast or always prone to have cuts and scrapes and bruises more than their sister or brother. We see this supported in the evidence that indicates that people with ADHD have twice the average medical expenses of people without ADHD, and they're also at significantly higher risk for motor vehicle accidents and traffic violations than people who don't have ADHD. We know that people with ADHD are much more prone to poor academic outcomes. Part of this can be explained by the incredibly high rates of learning disabilities among children with ADHD. We know that up to 50% of children with ADHD meet criteria for one or more learning disabilities. Specifically, they're at risk for reading LD or dyslexia. And if you think about that, to me, it makes sense because of how complicated it is to learn to read. You first have to learn all the letters, then you have to learn all the sounds of the letters, then you have to put the letters together into phonemes and be able to do those sounds. And then you have to put those together into words and then understand the meaning. And then you have to put multiple words into a sentence. It's really complex, and every step is really predicated on the idea of understanding the previous step. And at first, it's not very exciting, and you don't get a lot out of it until you can make meaning of those words, which is multiple steps down the road. And if you have a kid who struggles to pay attention and is prone to boredom and is prone to feel like boredom is painful, which is how some people with ADHD describe boredom, it makes sense to me that those first couple steps, you really struggle and you stop giving forth as much effort, and it becomes more boring and more frustrating. And so again, when we're talking about kids with ADHD, we also need to be screening for and looking for, do they need extra support in learning how to read and extra support academically? We also consider that these are kids who, even if they do read well, they're more likely to be disruptive, get out of their seat, be sent out of their class, and therefore receive less instructional time than their peers. They're also more prone to daydream and not pay attention to the teacher during class, and again, receive less instructional time. And they're more likely to struggle to complete homework after school. And they're more likely to have a parent with ADHD who has difficulty setting up the structure at home to adequately support them doing homework. Multiple reasons why children with ADHD experience poor academic outcomes. Unfortunately, we also see that children with ADHD have poorer peer and family relationships than typically developing children. Again, I think that this is for multiple reasons, multiple ways to explain this. One of the things is that we see that ADHD tends to run in families. And so we tend to see kids with ADHD have at least one parent with ADHD. And the chaos that can ensue from a parent who's struggling to set up their own structure and stay on top of things, while also managing the schedule of a child who isn't as able and is developmentally delayed in their ability to accomplish those goals, leads to a lot of tension. We also see that children with ADHD typically receive negative feedback at twice the rate of kids typically developing children. Things like, sit still, stop running, why are you moving, why are you so close to me, be quiet, what are you doing? Just stop, right? We see these things. I see them repeatedly in my office when a child comes up for ADHD and the parents just trying to, really often coming from a place of loving, trying to help this child to behave differently. But to that child, it's so often just this negative, this constant barrage of negative feedback about doing things wrong. We also see that that leads to increased frustration tolerance, and it contributes to these increased risks for anxiety and depression amongst these children with ADHD who are receiving this frequent barrage of negative feedback and contributing to this sense of learned helplessness. Well, I can't win. I'm not doing these things on purpose, but I keep getting all this negative feedback from all these things I'm doing. So I'm just going to lash out, right? And argue. And what do I have to lose? We also, unfortunately, see that parents of children with ADHD, likely due to so much of that stress from trying to manage that behavior, experience divorce and separation far more often than parents of typically developing children. You take impulsivity and you add in hormones, and we're We're at risk of teenage pregnancy, which we see occurring at a much higher rate for children with ADHD. Again, difficulty understanding, thinking things through, planning things out, learning from consequences. And so we see that unfortunately occurring at high rates. And then we also see that children with ADHD are at significant risk for earlier substance use and substance use disorders. You take that impulsivity, you add in peer pressure, social isolation, increased risks of anxiety and depression, and you end up with these children, adolescents who are just trying to self-medicate to survive some of the difficulties they're experiencing. And again, not feeling like they fit in, oftentimes just contributing to this willingness to try anything to feel differently and to feel better and to feel accepted. One of the things that I often hear when I'm working with a family in a family where the child has ADHD is that, well, we're raising Bobby because Bobby's mom and dad are struggling with drugs, and yes, Bobby has ADHD, but we really don't want to put him on medication because we're worried that he's going to develop a substance use problem. And while I completely understand how a family can get there logically and can worry about that, I've not had any of those instances where that parent was addicted to the ADHD stimulant medication, right? Or where that parent's addiction is traced back to that ADHD stimulant medication. In fact, what the evidence bears out and supports is this idea that children who are adequately treated for their ADHD are at significantly lower risks for later substance use problems than children whose ADHD is undiagnosed or untreated. And so really adequate treatment, and when we talk about adequate treatment for ADHD, we're talking about at some level the inclusion of stimulant medication or a trial of stimulant medication to see if that was appropriate. But the children who are adequately treated for their ADHD have decreased risks of substance use. So that prescription that is managed by their provider decreases the risk for later substance use problems. And I feel like that information is often critical to share with families as they're making this decision. And obviously they need to be the ones who make the decision. I want them to make that decision with all available information, and that piece is pretty critical. The other thing, unfortunately, is we see people with ADHD have an increased mortality compared to people who don't have ADHD. And I think, all those things we just talked about contribute to that, right? Increased risk of motor vehicle accidents, of substance use, of just overall accidents, medical accidents. We also know that people with ADHD are more likely to struggle with routines and treatment adherence. And so if you have a chronic condition like type 1 diabetes and you're supposed to be checking your blood sugar and administering insulin at regular intervals, but you struggle to keep track of time and to plan out your day, you're more at greater risk of poorly managing that condition. And that puts you at greater risk of death. Just briefly, very briefly, I'm going to talk about treatment. And, I think anybody who's worked with a family with ADHD has had this conversation, should have had this conversation, but surely you've had this conversation at some point. We're talking about most of the time is, medication versus therapy, right? Which one should we do? And a lot of families come in with a strong opinion one way or the other. One of the things that's important to be really clear with families on, and for us to really make sure we have a good grasp of, is that medication is the only known effective treatment for the core symptoms of ADHD. When we're talking about the hyperactivity, impulsivity, and inattention, the medication is the only thing that actually addresses those core symptoms of ADHD. There's some support, not enough for me to feel confident in it, but there are some therapies that make some impact on specifically the inattention and maybe a little bit the impulsivity, but really the magnitude of that effect is not nearly as positive as it is for the medication. And so we know if those are the symptoms we're trying to address, medication is really where we need to go. When we talk about therapy, though, we know that therapy can be very helpful for the associated deficits. It can help with emotion dysregulation. It can be very, very helpful for family and peer conflicts, for lower self-esteem, for sleep difficulties, for overall compliance at home, for getting a child to follow a parent's directions. Again, it can do a lot of things to give that family a sense of relief and to improve a child's outcomes later in life, but it doesn't address those core symptoms. And so one way to think about it is medication is not going to directly treat noncompliance. If a kid's not listening and not following directions, and that's the parent main concern, yes, I can get you hooked up with somebody to talk about medication, but that concern's not going to automatically get better. The pill's not going to teach your child to follow your directions. At the same time, if your biggest concern is that your kid won't sit still and is running around all the time, we can do therapy 3 times a week, all day, every day. But our ability to really get your child's internal motor to slow down, we can't do that through therapy, right? We're going to need the assistance of medication. And really what we see in some of the larger studies is that what's recommended for most children is a combination of both. And that when children are on receiving medication management in addition to behavior therapy, that families are experiencing much better outcomes, and that children are on lower doses overall of medication. One of the things to consider is a child's age, and that has a pretty profound impact on how I personally recommend this and what's advised by a lot of the literature. For children who under 5, it's not recommended to start with medication in pretty much any circumstance other than very severe ADHD, where the impulsivity and hyperactivity is creating safety concerns. The kids running out into the street, the kids getting up in the middle of the night and running all over the place because they can't slow down, right? And in those instances, we might start with it, but generally, preschool age, we're talking about starting with therapy, behavior management therapy. Around 6 to 11, if it's severe, again, we're recommending starting with both. But generally at that age, we're trying to start with behavior therapy and then add in medication if that's needed above and beyond to help the family deal with stress and to help improve those outcomes. And around age 12, our plan is generally to start with both. Is that we're going to start behavior therapy, and I'm going to go ahead and give you a referral for medication management to talk about some of those options. And again, just kind of the idea being, if we can manage some of these things and just teach a family to manage and be more accepting of these things and guide greater compliance at home without the medication, we're going to try to do that. But we're also going to educate the family that some of this developmental delay of not being able to learn from consequences, not being able to sit still, is part of your child and who they are. And short of medication, we're not going to be able to change that. So we talked about what ADHD is. I think it's important to spend a little bit of time talking about what ADHD isn't. ADHD isn't easily diagnosed or readily diagnosed in a child who has a really poor diet, frequent sugar and caffeine intake, where they have they more or less do the grocery shop and eat whatever they want, whenever they want. It's really difficult to diagnose ADHD then, because the child's blood sugar is cycling from low to high. There's really, just overall, usually it speaks to inconsistency at home. There's no real structure environmentally. And this is where I expect for these kids, I don't see this very often, but when I do, this is a kid who typically is doing better at school than they are at home, because at school meals are more prepared. They don't have as much access to these things. And so I see that behavior much better at school than I do at home. But I think that it is something that you want to screen for when you're talking about ADHD. A lot of families will talk about red dye or other things that maybe have been talked about in the literature, some places more often just on the internet, not as much in the scientific literature, but it has been examined. And we do know that there's some kids who have food allergies where the symptoms to a food allergy can mimic some of the ADHD symptoms. That seems to be very, very rare. Obviously, if a family says that they've cut out red dye and a child's behavior improved, I'm not going to argue with them. Whatever works for you, keep doing, especially if it's very manageable. I mean, the kid not being able to have their favorite Kool-Aid or drink, Mountain Dew Code Red is not the worst thing in the world. So I'm fine with that. But it doesn't typically explain the overwhelming majority of cases that come in, but still we want to screen for what does that kid's diet look like? How much sugar intake do they have? How much caffeine intake do they have? Because that can contribute to some of those negative behaviors. More often than not, this is just kind of the canary in the coal mine for the next issue, which is really, really poor sleep habits. And I see so often a family will come in and they're complaining about their child's behavior. They're complaining, they think this kid has ADHD, and it turns out that this kid is staying up till 2 a.m., 1 or 2 a.m., watching TV, playing video games, watching TikTok, and then, having to wake up at 6 a.m. for school, struggling to wake up for school, falling asleep during class, really irritable, more hyperactive, because honestly, they're hyperactive. We call it paradoxical hyperactivity. They're trying to keep themselves awake in the same way that as an adult, we might, if we're on a car trip and we're getting sleepy, we might turn on really loud, really fast music and start trying to dance to it to keep ourselves awake. Kids will do this too when they're sleepy, and they'll start moving more and appearing hyperactive when really they're just tired. And so we really want to make sure we're looking at sleep, because we know that inadequate sleep in children can mirror symptoms of ADHD. 1 week of inadequate sleep for a child leads to increased irritability, behavior dysregulation, and decreased attention problems. And that's for kids who don't have ADHD. We really want to be on the lookout for that. One study did a sleep intervention for every kid that came into the clinic complaining of behavior problems before they did anything else. And they found a 75% improvement in behavior problems across the board, to the point where some of the families didn't even feel like they needed services anymore once their child's sleep had improved. It can be really, really powerful to work with families and assess for and address sleep prior to addressing other concerns. We know that that's important even for kids with ADHD, because kids with ADHD are more prone to have difficulties with sleep. Their circadian rhythms make them more likely to be kind of night owls, stay up later and sleep later, which does not fit well with how our school schedule typically works out. And we also know that for children with ADHD who have problems with sleep, their ADHD symptoms are often worse, right? So sleep problems mirror ADHD. ADHD causes sleep problems. If a child has ADHD and sleep problems, the ADHD is more severe. Sleep is really important when we're talking about ADHD. We also know that those same sleep interventions that work for typically developing children work for children with ADHD, lead to improvements in their ADHD symptoms. And actually, over the long term, if we can get a child, there's some evidence suggesting if we can correct a child's sleep routine early on, if they have ADHD, they actually have much better outcomes later on, and their ADHD prognosis is drastically improved. Again, we really want to talk about sleep when we're talking about ADHD. We want to make sure we screen for that. Another important consideration is trauma. We want to make sure that when we're talking talking about ADHD, considering ADHD, we're considering the potential impact of trauma, because we know that children who've experienced trauma have structural changes to their brain very similar to children who have ADHD. We see them having the same developmental delays, abnormalities in their hypothalamic pituitary and adrenal axis, and in their prefrontal cortex that can lead to many of the same symptoms that we see with ADHD. Unfortunately, this isn't always considered. And if we look at children who are involved in the child welfare system, involved with DCS and state custody, we see that they're frequently diagnosed with ADHD at much higher rates than the general population. And there's, again, some evidence to suggest that when you actually do an evaluation with those kids, with children and child welfare, when you're considering all possibilities and doing a really thorough assessment, we see the most common diagnosis is actually post-traumatic stress disorder, PTSD, for children and child welfare. Kind of should be the leader, but ADHD is the leader there. And so really understanding that if you have a child come into your office who's in state custody and they're already diagnosed with ADHD, we're not going to assume that, oh, that diagnosis must be correct. We're going to dig deeper and see, does that make sense? Because we don't want a kid with PTSD diagnosed with ADHD when they don't have it. And if they do have both, which they very well may, we want to know that, because we can expect that in that situation, the outcomes are going to be worse, that this is going to be a more difficult case, that we're going to want to consider to be more severe and rally more supports earlier on, because children with ADHD and trauma are at much higher risk to display increased aggression, experience more arrests, and have more suicide attempts than people who have either one of those diagnoses individually. And here's my Venn diagram. Every presentation needs a good Venn diagram. And again, there's just tremendous overlap between those symptoms. A kid may come in and they say he can't sleep, he's restless, he's organized, he's disorganized, all over the place, doesn't seem to listen or pay attention. Well, that could be for a lot of reasons. And obviously, if they say that, you're going to consider ADHD, but don't live your life over here and ignore these things. Yes, these things are harder to talk about, but they're critical to consider, because if this is the explanation, the full explanation for what's going on, the treatment plan is going to look much different than if we're all over here, right? And so we gotta look at some of those things and consider many of those possibilities. So the question, and probably why many of y'all decided to tune in today, is how do we untangle all of that? How do we make that distinction? One of the things I think is really important, and I'm going to encourage this for every intake. I'm going to encourage every clinician who does any type of diagnosing, does any type of psychological intake, do a therapy intake, include a trauma screening. This is the one that I prefer. This trauma screening is, it's the ACE-Q put out by Dr. Nadine Burke-Harris, has a phenomenal TED Talk on ACEs, but this is the one that I typically use in my practice. And it's just a questionnaire for ACE or trauma exposure. There are lots of options for this. You don't have to use this one. It is one that is freely available, and it's de-identified screener. So it just basically gives them this list and says, how many of these things have you been exposed to in your life? It's not an exhaustive list, and with different kids, I might use something different. But what we want to do is we want to see, has this child lived through potentially traumatic events? One of the things we want to be careful of is including this in your practice and stopping there, though, because what we know is that exposure doesn't mean we're going to get a diagnosis of PTSD. Not every person exposed to a potentially traumatic event develops PTSD. In fact, the opposite is true. Most people experience one or more potentially traumatic events in their lifetime, and most people do not develop PTSD. Resilience is the norm. However, we want to make sure that that resilience is already in place, and even if it is already in place, we want to support it and foster it. But if it's not in place, we definitely want to be in a position where we can help that child, that family, to respond to their difficulty with that potentially traumatic event. So if they screen positive for being exposed to a potentially traumatic event, then I would encourage to follow up with a trauma assessment. There are, again, lots of options for this. I listed out several of them here. There are more than this. One of the things is I highlighted several here that are free. It's my favorite price point. It's the way to go, especially for many of y'all working in community mental health. They're also typically pretty brief. This isn't going to take you an entire session to administer. It's pretty easy to administer and interpret. I'm going to focus on the CATS, though, the Child and Adolescent Trauma Screen, as it's the one that I use most frequently in my practice. It's this 20-item screener, and it goes through pretty much the DSM criteria, right? It's going to have them or a caregiver to rate these symptoms from never, once in a while, half the time, almost always, for each of these criteria. And then what you do is you're going to tally these up, add them here. And if it's more than 15, we're going to say that they've got clinically significant post-traumatic stress symptoms. Then the scoring will take you to go back and say, well, these 5 actually load onto the first criteria. And so if they have a 2 or a 3 on any of the items there, they meet that criteria. And basically it will take you through, and using this, you can determine whether or not a person meets criteria for PTSD, and you can formally make that diagnosis, which I think is very important. Because if you're working with kids, especially kids who are coming, if you're working with kids who are coming in for ADHD, you need to be competent in screening for post-traumatic stress disorder and diagnosing that, because it's going to happen that you're going to have a kid who has PTSD instead of ADHD, or has both of those things. It's going to happen. And so I encourage you to gain comfort with one or more of these assessment tools that are freely available. And you can Google these online and access them, but if you have trouble, you can email us. I'm happy to to point you in the right direction, help you get connected to this, right? So again, I'm going to argue for every kid who comes to your office, you're screening for trauma exposure. And if they're exposed, you're doing a screening for post-traumatic stress symptoms, right? And diagnosing that if appropriate. But I know that you're going to have kids who screen negative for both those things or screen positive for that, but they still have this concern that ADHD is going on. So what then, right? And so in that instance, what we've been encouraged to do is to do an evidence-based assessment, which means that we're going to do a multi-informant, multimodal assessment. We're going to get information from more than one source in more than one way. The ways of getting information for an assessment often include doing interviews, right? This is doing an interview with the caregiver as well as with the patient, and talking about symptoms. You can do these, there's some structured interviews, some semi-structured interviews, and unstructured interviews. The majority of you, I imagine, are doing semi-structured or unstructured, kind of your organization has come up with an interview that gets the information you need for your billing purposes as well as for diagnostic purposes. I think that's okay. Very few people, I don't think I've met anybody in community mental health who uses a structured interview. Those take a really long time, and our families tend not to come back. And so if we spend a lot of time in our first session doing a 4-hour structured interview, we may not see them again. The other option is observations, classroom observations. This information can be invaluable, but I also imagine that most of us don't have the time to do that, to go out to a school and actually observe a child in a classroom setting. Some of you may work in schools where that's more feasible. Also, a consideration there is that if you do an observation, a classroom observation of a child, you need to do it before you've met that child, because after you've done the interview, you're trying to watch a child in the classroom and they see you and they're like, hey, and they're like waving at you because they know you. It doesn't give you really good data on an observation. So again, it can give you really good information if you're in a position where you can do that before you meet the kid, right? The other option is like a neuropsychological assessment. You might do like a cognitive assessment or an assessment of working memory. A really popular one is a continuous performance task, where it's directly assessing attention span, ability to focus, distractibility, those types of things. Unfortunately, a lot of the research doesn't support those as being very helpful in an assessment, because there are lots of reasons why kids may have deficits in those areas, and it's not exclusive to ADHD. And so while in some instances those are helpful, and the CPT tends to be the better one of those to choose, they don't seem to be worth the time or the expense, because those require more training, specialized training to administer than the trauma assessments. And so those typically aren't go-tos and aren't recommended. What is readily accessible and affordable and time efficient are rating scales. And rating scales can be really easily administered to multiple informants to get you a variety of information. And there are a lot of different rating scales, and we'll talk about a few here in a minute. For the interview, I include everybody to think about what interview questions you ask and make sure you're hitting some of these high points. When you're doing an interview for someone with potentially has ADHD, really for anybody, you want to get a timeline of those symptoms, right? When did those symptoms first start? When did you first become concerned? Why now? What brings you into the clinic to address these things now instead of when you first became concerned? And you just want to get some sense, because again, you're looking for, are there several symptoms present before age 12? And you're also trying to get some sense of the dysfunction that's coming from these. You want to get a family history. Does anybody else in the family have ADHD or any other diagnosable psychiatric condition? Because we know that it's highly heritable, that if they do have a family history of ADHD, it is more likely that the kid is going to have ADHD. But there are kids who have ADHD who have no family history of ADHD. So if they don't have that family history, that doesn't mean you can't give them a diagnosis of ADHD. Also, there's a high likelihood that there were people who were undiagnosed in the past. When we talk about those symptoms, we want to talk about the frequency, severity, and duration of those symptoms. Again, we're trying to get at how dysfunctional are these things, also trying to get a sense for whether or not this is developmentally appropriate or not. Because for some kids, they may be saying, yes, I mean, my 3-year-old just won't sit still. I try to read them a story and I get 5 minutes and they're not listening anymore, and I'm trying to do something else. And well, that's a 3-year-old for you, right? But if they make that same description for a kid who's 12, they won't sit still for more than 5 minutes of me talking to them. They can't focus. They're all over the place. Well, now I'm thinking that's developmentally appropriate, right? And so again, I want to get a sense of how often is that happening? How bad is it? How long does it last? And then think about that in the context of how old is this kid? We want to know which settings it's happening in, and we need to know that several symptoms are present in at least 2 settings. We want to always assess for sleep patterns and know what their sleep habits are. And we also want to understand that sleep problems can contribute to ADHD-like symptoms, but also if they have ADHD, they're more likely to have sleep patterns. Regardless, sleep is going to be an important thing to talk about. You want to know what's their bedtime, what's their wake-up time, what's the bedtime routine, the 2 or 3 things they do before bedtime every night. How often do they wake up during the night? How easy is it for them to go back to sleep when they do wake up? We need to talk about these things because these may be intervention targets that are going to give you pretty good bang for your buck as far as what you spend your time on can lead to some pretty positive results. And I encourage everybody in any clinical interview to talk about strengths. What does this child do well? This is important for a number of reasons. First, it's important because we know that for children with ADHD, they struggle academically and they struggle often with parental relationships and sometimes in the structure of home. And so if we can build on those strengths, we can actually help foster resilience for children with ADHD. The other thing is it can be a pretty decent prognostic indicator, because if a family can't think of anything that a child does well, that's a really bad sign. And it means that we need to spend a lot of time working on those things. And for me as a clinician, that might be an indicator that I need to have a conversation with them about medication earlier than I might with other families, because they need a win, right? They need something positive they can look for, that they're seeing this child do better and that they can recognize progress in, because they're probably not going to be very motivated at all to do my behavioral interventions if they don't see any change in their child's core symptoms. So those are some of the interview questions that I would encourage you all to consider including. Rating skills really tend to be the bread and butter of ADHD assessments. There are a lot of different ways to do this, but the reason that they're so frequently used is they're cost efficient and time efficient, and they allow you to get information from multiple different settings. You can give a rating scale to a parent, a teacher, a coach, a youth group minister, their babysitter, right? You can get information from multiple different settings. Now, I don't know if there's any situation where I've given one to all of those people, but every single person I've listed has been somebody I've gotten a rating for some kid at some point in the past, because that's what we needed. That's who was available. Their rating skills differ as well. You know, one of the main differences is in cost, and usually the cost differs based on whether or not a rating scale provides normative sampling. Normative sampling means whether or not the scores that person gives the child are compared to scores given by other raters of children the same age, to say, you know what, this kid's behavior is similar, yet yes, they're getting up and getting out of the seat all the time. But you know what, like 80% of other parents of kids who are 4 said that happened most of the time for their kid. So actually it's not that abnormal, right? The BASC-3 is one of the rating scales that does a pretty good job of that. It has more items. It assesses for anxiety, depression, in addition to ADHD, and it gives you that readout, that comparison. However, it costs more money, right, per administration. The Vanderbilt is one that's freely available. It does assess for ADHD symptoms, and it allows multiple informants, but it does not allow for that kind of layer of comparison. And so the Vanderbilt, which looks like this, many of you may be familiar, asks a lot of questions about, you know, does your child not pay attention to details or makes careless mistakes? And you say never, occasionally, often, or very often. Very similar to the trauma assessment earlier. And what you're doing is you're taking all of these responses and you're adding them up here. And then once you've added them up, they filter into this scoring sheet, right? Where you're seeing, okay, on those first 5 or those first 9 questions, how many of those items did they score a 2 or a 3 on? And we need at least 6 of those items that they had at least a 2 or a 3, right? And if that's true, and that's all we have, then they're going to get predominantly inattentive subtype, right? We're just basically checking off boxes, whether that symptom is present or not, without really considering in the questionnaire whether or not it's developmentally appropriate behavior at that age or not. Still, this is a really good tool and one that's very frequently used and has a lot of evidence. This has the benefit of also screening for oppositional defiant disorder, conduct disorder, and anxiety disorders. Now, again, these are more screeners, so you're not going to make a diagnosis of those disorders based on this questionnaire alone, but this questionnaire plus your clinical interview assessing other symptoms of that may give you that information. The other benefit of the Vanderbilt is that it does have this dysfunction screener. So you're asking, do they have any performance deficits in relationships with peers or with writing or with reading or in other areas? And so again, that information can be very diagnostically relevant. And it says here, they need a score of a 4 or 5 on one of the performance questions in order to get a diagnosis. So that's the Vanderbilt, freely available. You can download it online. Here's a copy of the BASC-3, which is the one that I'm more partial to using. I like it because it does give you that comparison point to other peers and considers developmental level and gives a wide array of areas. It assesses for hyperactivity and attention problems, but it also assesses for anxiety, depression, aggression, atypicality, and withdrawal. And with this, what you're looking for is the higher the score is, the more it's up in the gray area over here. That means the more it stands out from other kids that age who are rated by their parent or by their teacher or by themselves. It also has this at-risk range, and then it has down here where we're considering it more appropriate, less at risk, less indicative of a problem. And so it gives me that comparison point. It also has these adaptive areas that are assessed. So it will give me an indication of, are there deficits in social skills or adaptability to changes in routine or ability, functional communication or activities of daily living, which again is going to indicate that there's some dysfunction potentially associated with the symptoms over here. And I like this one again because it does that. It also gives me the ability to check off some of those boxes. The Vanderbilt goes straight on to the diagnostic criteria for ADHD. The BASC does as well, and it will give you part of the scoring, will give you whether or not your child, based on those ratings, meets symptoms for each of the criteria listed. So that's BASC-3, which is just another option. Again, you want to get multiple raters. You need multiple settings. It doesn't have to be parent and teacher. Some kids are homeschooled. Sometimes you're doing an assessment in the summer or during winter break. In those situations, do the best you can. Sometimes I try to get previous teachers. Sometimes, again, I'm getting coaches, I'm getting babysitters. I'm getting a family member that they don't live with, but they spend a lot of time with. So it's a different setting and they don't live in the house with them, but they, grandma who lives across the street and keeps the kids every day after school until mom and dad get off work. That I've used many times, right? Because there's a different set of expectations in that household. If the kid struggles with both different sets, I'm more likely to diagnose ADHD. One of the things to consider when you're doing this is that you're not going to get perfect overlap between multiple raters, and we're not expecting that. We know that 2 biological parents in the same household rating the same child are likely to have different responses just because they're different people and they have different tolerances for different behaviors. And so what we're looking for is that we have several inattentive or hyperactive impulsive symptoms present in 2 or more settings, not all of the symptoms present in every setting. Everybody doesn't have to identify the exact same problem in each setting. But what we do want to see is that we have some symptoms present in multiple settings. So maybe they have 7 of 9 symptoms present at home, and maybe they only have 4 of 9 symptoms present at school. Well, that's okay. There may be some reasons for that, but I'm still going to diagnose that child with ADHD because there are some symptoms present in both settings. There may also not be an opportunity for that rater to see some of those symptoms, just depending on their relationship, how much time they're with that child. They may just be less aware of all areas of potential deficit. And so again, we're not looking for total agreement with those rating scales. There are a couple other things that I think are pretty important to consider when we're looking at ADHD and considering ADHD. One of those is we know that there's a pretty significant gender difference in the diagnosis of ADHD. Males are diagnosed at a rate of 3 to 1 with ADHD. Part of this, some will argue, is because it's just more prevalent in men than it is in women, or males and females. The other reality is that it's often underidentified and underdiagnosed in females for a variety of reasons. One of the main reasons is that girls typically display fewer hyperactive symptoms than boys, and for that reason, they tend to be less diagnosed. The girls also, 75% of children with ADHD have a comorbid diagnosis, which is true across the board. Girls are more likely to have anxiety or internalizing disorders like anxiety or depression. And oftentimes when someone's doing an assessment on a girl who potentially has ADHD and she displays anxiety symptoms, they go, oh, anxiety, that explains her inattention. That explains kind of everything. And they couch it all under that internalizing diagnosis, and then kind of throw out the ADHD diagnosis when that may not actually be appropriate. It may be that the mechanism under which that child developed anxiety and depression is due to untreated ADHD, that girl was having a hard time focusing and paying attention and following directions and doing all of those things that we commonly talk about for boys. And then due to getting that negative feedback and struggling with that and kind of beating yourself up about it, developed anxiety and depression along the way. And so we want to make sure that when we're doing an assessment, particularly when we're doing an assessment with girls, that we're conscious of that. We're conscious of that potential bias, and that we really challenge ourselves to look deeper. One of the things that's been shown to potentially be helpful in that situation is to include self-report scales, because we know that everybody's better at reporting their own internalizing symptoms and their own inattentive symptoms than external reporters. And so when possible, getting girls to do a self-report rating can be very informative. Now, we don't typically do self-reports until about age 9. Most of the rating scales aren't designed to be completed by kids until about that age, but you can also do it through the clinical interview, talking to them in that way. You want to get as much information from them as you can, specifically when we're talking about girls here, just being careful with that. The other issue, which is very, very important to talk about, is when we're talking about doing assessments with children of color. We know that children of color are vastly underdiagnosed with ADHD and overdiagnosed with conduct disorders. Part of this is highlighted by the preschool to prison pipeline, which shows that children of color are much more likely to be suspended and expelled in preschool and daycare, and that has a cascading effect to lead to increased risk of incarceration in adulthood. Children of color are more likely to be viewed as mature and older and more intentional with their behavior, less innocent than their same age peers. And this is a huge problem, right? The systemic racism, which is pervasive and also very present in our field, right? I think a lot of mental health professionals like to consider themselves that I'm not biased, I don't make those errors, but so much of this is implicit, and we have to work daily to be aware of these biases in order to counteract them. And so, we want to make sure that when we're doing an assessment with child of color, that we're considering the possibility that these past diagnoses they may have come in with of oppositional defiant disorder, conduct disorder, may actually be reflective of an ADHD that was misdiagnosed. And we also want to make sure that we're giving them that fair assessment. We're really looking into these things and really assessing these things. The same thing is true for PTSD, which is underdiagnosed, despite minority families being at a significantly increased risk for exposure to potentially traumatic events. Again, we want to make sure that we're challenging our own biases on a daily basis with each intake to try to make sure we're giving the best care we can to the families that are coming to us looking for help. An additional hit also comes from children with ADHD. Children of color with ADHD are less likely to be treated with stimulant medication. which is considered the gold standard for ADHD. And so we want to make sure we're advocating for our families as well and making sure that we are trying to get them to get the same services that all the other children get, and that what the evidence supports being the most effective intervention. So just to summarize some of the things we talked about today, right? We know that ADHD is a genetic, prevalent, and chronic condition that affects a lot of people. When we're doing ADHD assessment, we should always screen for trauma. We should always assess current sleep routines and dietary habits. We should always gather information from multiple settings. We need multiple informants. We need symptoms present in multiple settings. We need to understand if we have a child in custody, they're often overdiagnosed with ADHD and underdiagnosed with PTSD, so we need to be super careful there. We know that girls are so often underdiagnosed with ADHD and overdiagnosed with internalizing disorders. Children of color are underdiagnosed with ADHD and overdiagnosed with externalizing disorders, while simultaneously being undertreated for their ADHD. And we also know that if ADHD is the appropriate diagnosis for the child that we're working with, that medication is an effective treatment for the core symptoms of ADHD, and therapy is very effective for the conduct problems and parental stress that so often accompany ADHD, and that we really need to work with families to help them understand all of this information and to use it in our clinical practice in a way that helps the families we're working with. I hope this presentation has been informative and helpful for all of you. If you have any questions, now is a fine time to ask. You feel free to type in the chat or to unmute yourself and ask. Okay, well, if anybody has any later, feel free to send me an email. Let me know. Happy to answer any questions later on that anybody has. Just a reminder to everybody to make sure you fill out your surveys from today. The link to the surveys in the chat box, and you will be sent your certificate for attendance after you complete your certificate. Also, just heads up that next month we will not be having a learning cafe due to fall break. We will be continuing on in November with our series, the Learning Cafe, and we'll have a presentation by our psychiatrist, Dr. Jeffrey Jacobs, who will be presenting on the anatomy of a psychiatry visit, how to help the doctor help you, talking about how to effectively advocate for children who receive psychiatric care, how to be prepared for those visits, and how to help them get the best services possible from their psychiatric providers. Thank you all for attending. I hope you all have a great day.